So I'd now like to invite Sam Meredith up onto the stage, please, to present to us Social Determinants of Multimorbidity within Emergency Hospital Admissions, a systematic review. So, Sam.
Thank you. So, hello everyone. I'm here. It seems quite quiet up here. Is that loud? Is it? Yeah. I feel like I'm ages away from it. Anyway. Okay, so I'm here to talk to you a little bit about the social determinants of multimorbidity within emergency hospital admissions. This has been the theme today, ED. And this was a systematic review study. So, yeah, my supervisors are Jennifer Down, Tony Marson, Sarah Rogers. I work under the person-centred complex care theme. And yeah, so we're going to talk about the social determinants of multimorbidity within ED. So firstly, what is multimorbidity? I think probably everyone knows, but just in case you don't, it's when a person has two or more coexisting chronic conditions. So that could be like diabetes and asthma, or maybe a cancer and a mental health condition, which is long-term. A few snippets of information from the research area. Around 54% of people over 65 in the UK have multimorbidity, and that was a statistic from 2015. And this number is projected to rise to about 2/3 of the population by 2035. Life expectancy gains in men and women will be expected to be, life expectancy gains in men and women, around 65% of men who surpass the average national life expectancy will be living with 4+ conditions, and around 85% of women. Multimorbidity is generally increases with deprivation, and onset multimorbidity tends to occur around 10 to 15 years in the most deprived areas compared to the most affluent. And to throw that all into a cocktail, where these individuals tend to increase hospital costs, ED use, hospitalisations, mental health care use. So basically they put a big pressure on the National Health Service. So the social determinants of health, how are these factors connected to the problem? So we've got two graphs on the screen. The left is from a study in 2012 by Barnett. And as you can see, the red line on the graph is individuals in the most deprived groups, or the most socio-economic deprived groups. And the black line on the bottom of the graph is the most affluent individuals in this population. And as you can see, for the same age group, so if you look at something like 45 to 49, individuals on the red line, there's a higher prevalence of multimorbidity in that age group compared to the individuals in the highest socio-economic strata. And similarly, you can see that on the right, we've got a graph looking at where individuals live, urban areas compared to remote rural. And as you can see, individuals in similar age groups, those who live in large urban areas, have a higher prevalence of multimorbidity compared to those who live in remote rural areas. So that was a bit of background on multimorbidity and how social determinants are connected. That was just a small insight. But what is this project? What are we trying to achieve? The main objectives of the review is to firstly identify the demographic and socio-economic patterns of multimorbidity within emergency hospital admissions. This is an area which is highly understudied. There's quite a lot of studies on multimorbidity within primary care, the social determinants of health of multimorbid individuals, but not a lot within ED, and how these social factors may differ. We wanted to also identify prevalence rates within this area, and we wanted to identify potential study design and methodology issues that people tend to carry out when looking at multimorbidity within this area and as a general, in general. So why did we undertake this research? The Academy of Medical Sciences in their 2018 report highlighted that there was a vast understudied area of multimorbidity within ED. The Academy also identified that individuals from deprived backgrounds were at a higher risk of multimorbidity at an earlier age, suffer worse health outcomes, and use more of the general health resource than any other group. And current research has not yet been synthesised around which social factors are the most important in this care sector. As I say, there is research out there on primary care and on general multimorbid populations, but not within this specific care sector. So methodology, what did we do to carry out the study? You can see the little flowchart on the bottom. We first scoped the literature. We then designed the review protocol and got that published. We implemented a search strategy and screened studies. We then undertook data extraction of the selected studies. We appraised the studies, and then finally we synthesised the evidence. We searched a total of 6 databases and 7 grey literature resources. We undertook a quality appraisal using the NICE or the NICE, however you want to say it, quality appraisal checklist, and used the PRISMA e-statement to synthesise the evidence. So where did we get the evidence from? I've done this graphic because it outlines really where the studies have been undertaken around the world. It was an international review. We were looking at studies from everywhere, mainly because there wasn't a lot of them. But as you can see, within the UK, there's 7 studies that have been undertaken on multimorbidity within ED. There was 1 study from Sweden, 1 from Denmark, 3 from Canada, and 3 from the USA. So a vast underrepresentation from South America, Africa, other parts of the world, mainly biased by UK studies. So results, what did we find? What were the most important factors? There's a word cloud on the right there which shows which factors were most commonly reported on. Deprivation, as expected, was the most important factor and was reported across 6 different studies, with individuals in the most deprived areas being as high as 2.7 times more likely to be admitted to ED. We also found that male sex was reported as being associated with emergency hospital admissions. This is a bit of a weird one because in general, when looking at emergency hospital admissions, females are more likely to be admitted. But as the individuals in these studies become more multimorbid and obtain more conditions, then males become more likely to be admitted. And I'm not sure what the mechanism is underlying this, but it might have something to do with how males look after themselves when they are multimorbid. Maybe males are less likely to use primary care. Maybe males are less likely to interact with certain services at a community level. Therefore, end up obtaining multiple conditions, end up having a bad health outcome, end up turning up to hospital with 4 or 5 conditions that maybe some of them haven't been diagnosed before. Maybe females have a better relationship with community care. That's just a hypothesis. I'm not quite sure why this is happening. Maybe someone will be able to give an insight from ED. And we also found that low education attainment, urban living areas and old age were associated. Those above 65 with multimorbidity were around 1.4 to 1.6 times more likely to be admitted to hospital compared to those under 65. We also found an interesting relationship with young age and multimorbidity in ED. So in general, you tend to find that, especially with physical multimorbidity, so individuals with 2 physical ailments, the older you get, the more conditions you tend to obtain, the more likely you are to attend ED. But when we were looking at populations where there was mental health conditions, in some of the studies, it was in 2, the youngest age group was just as likely to attend hospital as some of the age groups 2 or 3 age groups above them. So those individuals 18 to 25 were just as likely to attend hospital in some studies as those around 60 years of age with mental health conditions. This could be something to do with how individuals in the younger populations deal with their mental health conditions. We do know there's an epidemic in younger populations, but maybe individuals within the 30s, 40s, 50s who've had depression for a long time, maybe had a mental health ailment for a long time, they've interacted with the community services, they've developed their own coping mechanisms to deal with these conditions, and maybe the younger individuals need more support to deal with these problems, and therefore maybe that's why they're ending up in ED a lot more than some of their older age groups. Other factors associated where there was not that much evidence, but there was an inclination, was unemployment, lack of fruit and vegetable intake, exercise, BMI, smoking, and mental health. There was a general lack of evidence around ethnicity, income, and a few other factors which we'll get onto in the conclusions. And one thing I did want to highlight was the prevalence rates. So prevalence rates of multimorbidity in these studies that we reported on was between 7% and 87%, which highlights how vast the definitions of multimorbidity were in use. So just to give a bit of background on that, when people tend to study multimorbidity, the first problem they run into is, okay, how do I define it? How many conditions do I include? What is a long-term condition? And you get someone over here who says, okay, I'm including this 10, I think these 10 are relevant. And someone over here says, okay, I think these 350 are relevant. And then they both carry out the studies. One finds 90% prevalence, one finds 10% prevalence. Now that's talking at the extremities of what actually happens, but in general, you can see where that might lead. A lot of studies define multimorbidity in their own way, and therefore come up with a whole host of results, which are then hard to compare. So we do struggle in general multimorbidity literature comparing results, finding out which clusters, which conditions are most important, which social patterns are most important, because people have just defined multimorbidity in the way that they feel was fit for their study. So in conclusion, Deprivation, old age and male sex are associated with the increased risk of admission. These factors should definitely be taken into account when looking at multimodal populations in this area. There was some evidence to indicate that there was an increased emergency admission of younger populations or younger multimodal populations when they had a mental health ailment. There was also evidence to suggest that smoking, diet low in fruit and vegetable intake, physical inactivity, BMI, low education attainment, urban living areas and manual social class were all associated with an increased risk of multimorbid emergency admission. There was unclear evidence around income, living arrangements, homelessness and ethnicity. And just an example of that was the 2 studies that did look at ethnicity were in the United States. One was in Hawaii and one was in Florida. Vastly different ethnic populations that lived there, and therefore the patterns were quite hard to read into. Strategies to reduce emergency admissions within this population definitely need to take into account how people live and work, the social background that they come from, the factors that may influence emergency admissions in those areas. And I think it's vital that research going forward, not just on multimorbidity within ED, but multimorbidity in general, has got to abide by a core set of conditions if we want to start building foundations which future research in 10, 15 years can build on. There's work that's been done in Scotland defining multimorbidity by Bruce Guthrie and Stuart Mercer, who've identified 24 core conditions that should always be included on multimorbidity research no matter what. And then a wider 35 conditions which they recommend should be included depending on the study. We've also undertook our own research within emergency admissions, looking at a Delphi survey where we've also defined multimorbidity, taking the 24 conditions which were defined from the study in Scotland and also further refining for ED, which I know a few clinicians in here today took part in last year. And there it is there with the little the green square, which was that study, the Delphi survey. So these are the projects going on my PhD. I've just told you about my systematic literature review, which was the first, which I undertook a while ago. The second is a Delphi survey. The third, I'm creating a small area indicator looking at the multimorbidity admission burden across England. And the fourth is a clustering study looking at multimorbidity within HES data. So, yeah, thanks for listening.
Great, thanks. Thanks very much. That's really great. Don't go anywhere yet.
I will.
A couple of questions from me while people think, and we'll come to you in a second, Andy. Did anybody look at substance misuse, substance dependency as a factor? Because I would have thought as a clinician that may partly explain why males were more likely to be presenting.
Yeah, no, there was a few studies on the homeless population, but in general, most studies didn't include anything on substance misuse. There was a vast information was missing around substance misuse, ethnicity, living arrangements, quite a few factors. There was a lot of evidence missing in this area.
But I'm right, I presume, in thinking that you're going to start seeing what big data are available, that's already collected data that can start to interrogate some of these patterns.
Yeah, so one of the studies we're carrying out on the PhD is on clustering, which is a bigger population. It's our own HES data. We should hopefully be able to look into some of these things, some of these social patterns.
And Andy, is this a question?
It's a bit of a question at the start.
Good.
So, leading. So, thanks, Sam. Interesting, important work and a great presentation. With my knowledge synthesis hat on in public health, how many studies were set in the UK?
7. There was 15 overall and 7 in the UK.
So what I'd say you should do is you should also synthesize those 7 UK studies, because you've got studies that relate to the specific social, economic, cultural, health service design and access context within the United Kingdom, and you've just about got enough to put them together and do something meaningful, and then maybe make a comparison, because of course the health system in the United States, for example, is very, very different in terms of access to the UK. So that might be useful.
The other, don't forget, there was Denmark, Sweden
and Denmark had a study each.
Yeah, so they may be more similar to the UK than the US. So I hear what you're saying, Andy, but and Canada, which I think is a bit more like the US, though, isn't it?
I'd say it's National Health Service.
So I've got a tool. So in your review, you can assess the transferability.
Oh, great.
For the different studies. So
okay,
I
great.
can give you that.
Good point. So that's interesting way of thinking about international comparisons. Reminds me of a study I was reviewing yesterday where I made that very comment that all of their studies were only UK. So they were talking about how to change things. It's a pity you didn't look anywhere else where they may be doing it already. Would really like to ask Sam where he would like the results to land, but he can't say that because there's an election hanging over us. So we'll leave that hanging in the air. Because it's a bit of a banana skin for us, I suspect, Terry. On an early slide, you said that data was 65% male and 85% female. How is that differential explained in the findings?
Sorry, so that was just on the general introduction to multimorbidity. That was saying that individuals who surpass the national life expectancy, 65% of males will spend it with 4+ health conditions, and I think it was 85 of females. So that was not our data.
That's not data. That's just
sorry, I should
about
have made that more
as
clear.
people live longer, they're more likely to collect multiple conditions, but they may not be severe enough to be either ending or severely impacting on life. So that's because women tend to live longer, they're more likely to collect more multiple conditions, I think would be the explanation for that. It's observed data rather than cause, I think. But I might be wrong. I'm not an epidemiologist, and I'm not going to give Andy a chance to come back at me. Right, so thank you very much for being on time.